Two roads to the unconscious. Francine Shapiro and I worked together in 2001. We put a book together called Short-Term Therapy for Long-Term Change. And Francine was a wonderful, wonderful clinician, brilliant woman. And what I so enjoyed about her is her ability to think in dynamic terms. And in that book, she confessed that she thought EMDR was a psychodynamic psychotherapy. And that's why she was so bloody good at it. She was just quite amazing in her work. And if people watched her videos very carefully, she was very subtle when patients hit walls of resistance and the way in which she would work around resistance when the patient became deactivated. So as you all know, EMDR was discovered by her during a period of stress, and she was walking down actually by some river somewhere. It's a very pretty kind of image. And she started moving her eyes back and forth, and she noticed she felt so much relief. She began to realize that bilateral movement of the eyes and later bilateral stimulation of the brain in many ways can lower unconscious anxiety. So these are two roads to the unconscious. The one that we in ISTDP use, where we're seeing anxiety as the alert flag to the emergence of unconscious, repressed, or otherwise isolated emotions. I'm going to go through a little bit of history, a little bit of neuroscience. We'll zigzag around, and then we'll look at a video or two, actually. Hopefully I'll get through. This just mentions the book Josette and I put together talking about our system of psychotherapy, in which we kind of consolidated Davenlou's method of ISTDP and systematized it. But if you look at the psyche, what this roadmap is attempting to show you is how do we get through the ball, the outer layer of the patient's defenses, okay? Usually the outer layer of the ball is concerned by a structure that we call the superego or the superego pathology. If we dissect the psyche, we'll see the superego. And in that 2001 book, I kind of made the link that the unconscious attachment trauma is incorporated in the messages of the superego against the ego. And then there's a series of defenses that follow the dictates of the superego. The ego, the mechanism of the ego, is to make adaptive choices to help the individual through life, making the best choices, making compromises with their healthy superego, the adaptive environment, and the instinctual desires. And at the center of the ball is unconscious affect, or that is associated with attachment memories, attachments to the early parental objects. Hopefully, post-successful therapy, we're all shooting for this. We're doing a superegoectomy, and we have an observing and attentive ego, and the ego has only adaptive defenses left. Do we ever really get to that promised land? I don't know. But Davenlou's study of 632 patients, which was never published, but according to David Malin, had about a 70% cure rate. So, you know, using this method 3/4 of the time, we can be fairly successful. Anxiety is the cornerstone of ADP. Now, Lee McCullough, as you know, was a student of Davenlou, and she studied the triangle of conflict like all of us did. She coined the term affect phobia, just meaning that people who are anxious tend to avoid, okay? All therapies that we use that are humane. We regulate anxiety when it becomes too high, and signals of high anxiety or cognitive disruption, vagal overloading, and those skills are an essential component of ISTDP, as it is a central component of EMDR. Overcoming anxiety when it's a block against feeling is an essential component. What then is anxiety? Anxiety is a psychobiological event, according to Bowlby. It's a sense of danger. I've sat in many think tanks with great minds, Jaak Pansep, Steve Porges, among others, and nobody can find any difference in the psychophysiology between anxiety and fear. The only difference is the source of the stimulus. It's a normal emotion with adaptive value. We scan, we become vigilant, we have sympathetic arousal, we have a stress response, and in normal situations, there's fight, flight, and freeze. These can all be adaptive responses. Porges makes great emphasis on the dorsal medial vagal nucleus and the ventral medial. The dorsal medial nucleus is a very primitive nucleus, which is the sham death nucleus. That is when you seem to drop dead, and that's seen in diseases such as POTS. I don't know if people are familiar with that, but people will faint dead away, and it's quite a serious disease, overactive dorsal medial vagal nucleus. The ventral medial vagal nucleus is what we're all seeing our caregivers and great doctors using to soothe patients when they come into the emergency services, and that's the happy, smiling face, and that deactivates sympathetic arousal. But anxiety can be a disorder, as we all know. It's seen across psychiatric conditions, panic disorder, post-traumatic stress disorder, which is what we're focusing on today. It can be acute, single focus, or it becomes chronic, and we'll discuss why that is in a few minutes. It can be a generalized anxiety disorder, which is perpetual sense of arousal with no external stimulus. OCD, which has more complexity to it. We won't go into that right now. And phobic disorders, APT, anxiety, phobia. Now let's talk a little bit about trauma and how that interlaces. And we have to be careful in our language. We can't call everything traumatic, it's a childhood reaction to distress that's induced but unrepaired by a caregiving figure, usually caused by unresolved trauma in the mind of the parent. These attachment traumas have been categorized and described beautifully by Mary Main and her work. And we see these dormant attachment traumas in the minds of our patients who are subjected to acute adult trauma. Trauma then is a psychic state caused by an extraordinary event where one's sense of control is violated. It's brought about by situations which are life-threatening, painful, or terrifying, in which one experiences powerlessness. That's big T trauma, okay? And I think we need to be very, how can I say it, accurate in our description. It's the experience of powerless, meaning you have no escape, okay, that you can, from the toxic situation, okay? And you can see that's quite different than we're talking about with attachment trauma. Francine mentioned a third trauma, which I very much value, and that she calls it little t trauma. So these are the experiences of being bullied in school or bullied online, or being put in lockdown and not being able to surf, stuff like that. which we're all having our dose of little T trauma right now as we're dealing with the pandemic. So that's the third category of a trauma. But if we go through acute trauma of the big T category, we all know there's hyperarousal, the subcortical structures creating acute stress reaction. And I didn't put this on the slide, but in latest research, we now know, of course, we've all seen the amygdala as the center of this structure. And there's actually two substructures and a brand new nucleus, at least it's new to me, has been described in the central nucleus. It's called the BNST, bed nucleus of the stria terminalis. It coordinates short-term and long-term responses to various kinds of threats and stimuli. And that one subnucleus has been deemed by the neuroscientists to be hyperactive. But this is, for our purposes, what's so important, okay, as psychotherapists. The medial prefrontal cortex is hypoactive. That is the wiring circuit that turns off the amygdala and says, all clear, okay, no threat. So when you've been exposed to acute trauma, your medial prefrontal cortex stops working, okay? And it's quite amazing to see that. On fMRIs, I mean, when you see it, it's astonishing. And there has one other aspect of this that's really interesting. Facial recognition. Remember when I said about Porges's work on the ventral medial nucleus and smiling faces? Well, people who have exposed to acute trauma have hypoactive prefrontal cortexes, and that changes the way you react to faces. Friendly faces all of a sudden become sources of danger, okay? So you become more likely to have social anxiety and social phobia in the context of acute trauma and acute PTSD. So, not all acute stress reactions end up turning into PTSD. 25% of them transition into either acute PTSD or chronic PTSD. Chronic PTSD is far more common than was previously realized. 15% of the population report being physically attacked, molested, raped during combat. Half the victims are under 25. For women and children, trauma from violence and intimate relationships is more prevalent than events inflicted by strangers and accidents. So the epidemic of domestic violence. So we have the acute stress reaction, acute PTSD, and chronic complex PTSD. These are the diagnostic criteria, which you know. Now let's look a little bit more at what happens to the brain, okay? So you can see not only the amygdala is affected, but there's amazing amount of disturbances that occur throughout the brain. This is the prefrontal cortex area, dorsolateral, orbital frontal, and then the anterior temporal cortex and the amygdala. We'll skip that. These are some dysfunctional brain activity slides. Okay, the ventromedial PFC, remember that's what we were talking about earlier, that is hypoactive. The case that I'm going to show you today has speech arrest from activation of the inferior frontal gyrus, and it's gone on for 2 years. She was a member of a group, how can I say it, an HMO, for those of you that are not from the United States. It's like a large organization, almost like, let's say, the National Health Service in England. And they ordered a CPT for this patient, and it had absolutely no effect for her whatsoever. So look at this. I mean, this is just astonishing to me when you see all of these areas of the brain that are affected by both PTSD, acute PTSD, and chronic PTSD. Now, this is my favorite slide because it's the circuit of Papez. Papez was a neuroscientist from the 30s, and he wanted to decide what is going on in emotional memory and emotional learning. So he decided to inject rabies virus into the hippocampus of animals. And this is what he found. The virus went along this circuit via the fornix to the anterior nucleus, okay, to the anterior cingulate gyrus, and ended up in the mammillary bodies, okay? What we now know today is that in acute PTSD, the memory system of the hippocampal gyrus becomes, how can I say it, overloaded. It becomes stuffed with the traumatic memories, and it can't get out. And the problem with memory in the hippocampus is that you react to the memory as if it were occurring in the here and now. Okay, this is the here and now of memory. Okay, and you'll have the same physiological reactions to the event as if the event were still occurring. So the role of therapy, okay, either ISDDP or EMDR, is to loosen up the floodgates of the hippocampus and to allow the information to move out to archival bodies, to the mammillary bodies, which is the area of historical narrative memory. Historical, so the emotion is removed. You will feel emotions when you tell the narrative, okay? You'll feel emotions, but they'll be different emotions than the emotions you felt at the time. Do you follow the difference? A hippocampus, you feel the emotions of the here and now. Mammillary bodies, you create a narrative and a story, and you'll have grief, sadness, feelings of loss, feelings of inspiration. Oh my God, I survived. What didn't kill me? I'm a stronger person. You'll put it in some context once the information makes it to archival memory. So that's the circuit of Papez, and we owe it to the rabies virus. So some viruses have done some good things for us. This is a Josette slide, Josette Tenhavi de la Bea, which shows you the difference in processing speed between the cortex and the amygdala. The amygdala to the cortex is 12 milliseconds. The cortex to the amygdala is 30 milliseconds. So you've got quite a problem there when you're working with your patients, because their fear responses are going to be happening more rapidly from their memory system. And if your cortex is hypoactive to turn this signal off, your patients can easily move into panic states. And that's where your skills in anxiety regulation are just essential. So here we go. We have disturbed memory processing, loss of stimulus discrimination. This is huge. Though this is probably the one thing that when I supervise people, they don't highlight. That which seems similar, becomes the stimulus. Okay, it's not the bomb going off that explodes that I get reactions to. It's any loud noise that I hear. You lose the ability to make a distinct stimulus. It becomes a generalized category, triggers the same degree of emotional response. Your hypothalamus gets screwed up. Your stress response gets screwed up. Hyperarousal of the brainstem and the amygdala. Hyperarousal of the right hemisphere, right, Kristin, right? Where all the non-verbal emotion is located for our paraverbal therapists. Hypoactive left speech centers. And as you're going to see in this patient, terribly halting speech. We all know the answer to this. Who develops pathology post-trauma exposure? Neurotic people do, okay? This is a large epidemiological study. People who tend to experience negative affects when exposed to new events are likely to develop PTSD. The epidemiological data suggests the support for Shapiro's hypothesis that big D trauma can activate dormant little t trauma and attachment trauma, as well as underlying relationship failures. So, those memory networks become interlaced, and then you're stuck as the therapist, is you can't just walk the person through the event that they occurred, have them re-experience the affects at the event. You have to go back into the childhood traumas that are resonating with the events that have occurred, okay, in order to cure cases of complex PTSD. Okay, I think we're gonna call it there. Kristin, how much time do we have left for the video?
We have 20 minutes max.
Okay, well, that's what I figured, okay? So let's take a look. I've got two cases, one case of complex PTSD and then one case of simple PTSD, one in which the complex PTSD, I was using EMDR and brain spotting. Brain spotting is another technique that was developed by a guy named David Grand, where you use auditory stimulation along with fixed eye movements, not moving eye movements. So let me get out of here and get the video rolling.